to another edition of the Deals for Dentists podcast. Today we are joined by Darius Somekhian, and he is the co-founder of Pair Dental. And you can go to dealsfordentist.com and you can find their promo offer, which is they are offering to be a zero-cost matchmaker for getting paired up with a specialist. So Pair Dental is the premier marketplace to hire and seamlessly integrate specialists into your practice. Darius, thanks so much for joining us.
I'm delighted to be here. Thank you so much, Eric.
So Darius, tell me all about Pair Dental and how you help dentists.
Yeah, thanks. Pair Dental, it's a marketplace where practice owners can come find part-time, long-term, pre-screened specialists that come from an angle of a curated match. We are here to get you set up with someone that we feel will be the best long-term fit for your practice to deliver an in-house specialty experience. And the way it works is the specialist comes in with their own equipment, such as like the implant motor or the endo motor, depending on what specialty, along with the specialty instruments. And they're treated as independent contractors coming in, working off of a adjusted or collectible production split. That's the general concept. The way we get paid is we take 5% from the specialist's portion, leaving the practice owner with the full half of the 50%. And we're not just here to, act as a matchmaker to get you set up with the best specialist, but also to set the whole process up. We'll teach the office manager how to handle the billing. We'll concierge them through. We'll show them the consent forms. Like, there's a lot involved with setting up specialty, and all of that is included with incorporating specialty through Pair Dental.
And do you have all specialists from endodontists, orthodontists, prosthodontists?
We do. We have all the surgical specialties, including surgical prosts, as we call them. We have two kinds of prosts, surgical and restorative prosts, oral surgeons, endodontists, periodontists, orthodontists. We just started adding sleep doctors as well. And we also have a number of what we call advanced GPs, who they're not board eligible or board certified, but they do molar endo pretty well, or pedo they have experience with.
And when you say sleep doctors, do you mean airway and sleep apnea, or are you talking about like IV sedation?
Yeah, thanks for clarifying. Actually, both. We have dental anesthesiologists and sleep apnea doctors.
Now, how does this work state to state? Like, I'm in Massachusetts. I'm sure the state laws are very different in every state, from here to California to Texas. How does that work with state laws?
With anesthesia?
Yeah, or just in general, having a specialist come in as a 1099, or yes, definitely including anesthesia in that as well.
Yeah, well, different states vary in terms of acquiring a GA permit. In states like California and Texas, I noticed the oral surgeons travel with their GA permit assigned to their own address. In other states, like I believe Connecticut is one of them, I may be wrong, but they require that the GA permit is assigned to the actual facility. So they have to have a site inspection. And normally the oral surgeons in those states, they don't want to start, administering IV sedation until like a few months have gone by and they even feel comfortable with the right staffing, the right equipment, and what have you. As far as the independent contractor status goes, it's actually interesting you asked me that, Eric, because I just started hearing from a number of offices that we had our discovery calls with, our initial calls with, who are telling me that their colleague has been audited for bringing in a specialist under a independent contractor, and they're starting to shift over to W-2ing them. I think that may be the start of the other states to follow, but for the most part, all the other 49 states that I've seen, the specialists are treated as independent contractors. One of the rules in the whole A/B test that I saw stood out and applied to what we're doing, I'm not a lawyer, of course, but this is just my own personal interpretation, is that the provider that's coming into the dental practice would have to be doing a procedure that's normally out of the routine course of the owner dentist or the owner or the practice owner, which is the case. That's another reason why when you bring in a GP to come do the work with you as an associate, the W-2 would have to take into effect. Of course,
Mhm.
that's my opinion.
Yeah, I always, personally, I always felt, an associate general practitioner was a W-2, but a specialist, especially if they're bringing their own equipment, would be more of a 1099. But I guess that could be changing. Um, what about the staff onboarding? Let's say I'm bringing in, a sleep apnea specialist or an endodontist or orthodontist or really any of the specialties, and this is new to my practice. Everyone has to be on board, not just me, in educating the patients, educating the staff. Do you have a program where you onboard the staff as well?
If the practice needs additional staff to make the overall specialty days more successful, or even for their own practice needs on a day-to-day basis, we're happy to step in and use all of our recruitment resources that we have to help them attain some interviews. Um, the the way the staffing works is most practices will have at least 2 to 3 DAs helping out. One chair side just glued to the specialist's hip, a second helping to turn over the next operatory and chipping in on sterilization, and one just dedicated to sterilization. With oral surgery, you need two in the actual operating room, and you'll definitely need a third at least to helping out with sterilizing the instruments. And if you really want to keep a really busy schedule, you can add a fourth to help accommodate that. Um, Experience really counts too for a lot of these specialists when they're working with DAs that it's like their first time doing this or so on and so forth. So it's actually in that regard important that the practice understands what personality of specialists they're getting teamed up with, because you don't want to end up with a specialist that is impatient to teach a DA of yours how to properly assist, for
Yeah,
example.
especially if this is a new modality you're adding. We've never done, let's just say we've never done implants in our office, and now we're adding someone that's doing implants. That's a whole another animal that needs to be trained. Now, how does it work? Do I have a conversation? So let's say I'm looking for an endodontist. You've found one for me through your database. Um, do I meet with them first to see if it's a good fit? How does that work?
Yeah, so first schedule a call with us, and we want to get to know your practice and your practice needs. We'll take notes and we'll go back and figure out the best match that we think will be a fit for you. And if you're curious, we have close to about 1,200 providers, specialists registered with us. So although it's not as wide as it should be to cover like every nook and corner of the country within a 60-mile driving radius, which is the typical radius that we like to match with, but there are some decent options out there that we can set you up with, and we'll probably set you up with one. We have a very high success rate with our matching, our first time matches, I should say. After the call, we'll have a registration link sent over to you, and from that point forward, just expect an introduction to who we think is the best fit.
And do you provide specialists for all 50 states?
We do. We have some specialists in every state, and other states we have more of an abundance of specialists.
And I'm sure it differs, when you go from urban to suburban to rural, the availability of specialists can greatly vary. Um, okay,
Yeah.
so let's say I need an endodontist. How long does it typically take for, our first conversation until that endodontist is in the chair, filing away and doing endo? Like what's the typical, is it like 8 weeks, or what's the typical time frame?
From the day that you meet with the specialist, typical time frame is they give out like one treatment day in advance, 2 months out.
Mm-hmm.
There's some considerations here. One is the specialist's availability. The good ones are pretty busy, and they might have like 4 days open a month to give you like 1 day worth, right? The new grads that are coming out are more available,
Mm-hmm.
but they're more motivated to get started earlier than later. Second consideration is the insurance credentialing. The credentialing process to obtain specialty fee schedules as a in-network contract underneath the practice's EIN, that takes a decent 2 to 4 or 5 months, depending if you have HMOs or not. But some of the PPOs can take anywhere from a couple months to several months, depending on which PPO and what state. You could build out of network in the meantime, in the interim,
Mm-hmm.
but certain practices have different challenges with being able to line up a schedule that's actually worth it for the specialist's time. So, like, with that said, you should always keep in mind that like the initial impression you give the specialist is how it's like how organized and productive you are is very important. And you don't want to fall short on their expectations. Like, you want to make sure you understand what the production goal is in mind from both sides before you even start the first day, and bring up like, hey, for the first day only, what we're thinking is to achieve X amount in production goal, but there forward we can do X on a routine, consistent basis. And that's really the trick, is like after the first day is up and running, whatever you commit to, just keep it consistent, because
Mm-hmm.
it's the fluctuation of like how busy you keep them that makes them wonder like, okay, A, can they keep me busy enough if there's not enough patients, or B, if there's too many patients and it's disorganized, like, can this office like give me an organized experience? So the
Yeah, I
consistency of finding that optimal benchmark of scheduling is key.
yeah, especially if this is new for the practice. So let's say we've never done endo before and we're bringing in an endodontist. We have to look at ourselves in the mirror and make sure we're prepared with the staff, the supplies, the organization, the patient volume, and we can't be over promising. We're going to keep you busy, once a week, right off the bat. Offices have to be realistic about um, how they're going to keep these specialists happy and busy, and it's a symbiotic relationship. If and I think that first conversation and that communication is very key. Expectations and um,
Absolutely.
what do you need from us? What do we need from you? Let's make this work. And now let's say it's not working out. How does that work? Can we move on and you look for someone else?
Yeah. So, well, working through pair lends a lot of predictability with that regard, because although specialists are treated as independent contractors for the most part, they can terminate or you can terminate at any time. So who's to say that the orthodontist isn't just going to bail, leaving you hanging with like 50 cases revolving? Pair brings a little predictability to that, because the specialists will come and tell us, hey, we're thinking about leaving. I'm thinking about buying a private practice. How does it? They come to us often and say, how does it work? We want to have a conversation with the practice owner through you guys. And we ask them whatever you feel comfortable. Either we could bring it up or you could bring it up, but all we ask is to give some courtesy notice to give us enough time to find a replacement for you, so the practice doesn't lose any continuity of care. And normally we have a backup for a backup. The longevity of our matches, I mean, we've been doing this for about 6 years now. We've noticed that these matches tend to last for a good 3 years or so. The further out the specialist is coming from, proximity plays a crucial role in the longevity of the match. The further out the specialist is driving or flying in, the shorter it tends to live as a match.
You said flying in. Do you actually have specialists that are flying in?
Oh, a lot. Um, uh, you know, I'll give you some background on that. In California, we have Southern, Central, and Northern California. In Southern California, there's probably 4 to 5 times, if not more, specialists available than there are practice owners. In compared to Central California. In in Central California, there's pretty much just fee-for-service offices. Most of them maybe accept Delta. In Southern California, the average practice owner accepts anywhere from 5 to 10 plans. It's very heavy on Denti-Cal too, which is the state Medi-Cal
Mhm.
fund. So the payer mix is different. The scarcity of available specialists is drastically different, leading to this like perfect production recipe for a guy to fly in and produce more than twice than what they would make in Southern California for just a
Mhm.
day. Now, there's some challenges to flying, like post-op is obviously one of them. You can't get to the patient. That's a concern that comes up. The second is hauling all the instrumentation, all the equipment. What most practice owners in those underserved areas, as we call them, do is they come up with an arrangement where they tell the specialist, I just want to make this as comfortable as possible for you because I want you to come here long term. So let me just invest into buying all the instruments and equipment for you. I see that happen pretty often. I even have guys that hire their own private drivers just to drive them up the coast to do like back-to-back days. And
Mhm.
those offices, they never fall short of any production goals. Like the production is never an issue, and that's why the specialist loves to continue going there. Of course, from a lifestyle perspective, I get a lot of specialists that are like the new grad is always down for it. You know, they don't have like any domestic responsibilities, wife, kids, what have you. The guy who's got like the two-year old at home says to himself, like, I got some more expenses here and I still not done paying my school debt. So maybe I could just do this 1 day a week, but it's
Yeah.
got to be worth it for me. Like
Right.
I gotta bring home twice as much as what I would on a normal Tuesday in my local area. The older guy that's like basically like semi-retired who just sold his practice, they're they're usually open to it, but only from like what concerns me is they're more open to it from like a traveling like tourism perspective. Like, oh, I've always wanted to go visit that city sort of thing. And those relationships that doesn't really
Mhm.
sustain.
I think that like what you've just said, it really comes down to that initial conversation to find out, what each one is looking for, the specialist and the general practice office that's looking for the specialist to get those expectations and have that open communication. Because you don't want to have turnover, you want it to last, for sure, at least 3 years or more, because these specialists come in, they start to meet the patients, they start to build a rapport with patients, and you want to keep that going. It's better for everyone. But I could see the proximity being an issue. At first it's not so bad driving 60 miles, and then I could see that I would get tired of it. I actually, for a while, I was like a traveling implant guy, so I would go
Oh,
to different offices and place and restore implants. And I found after a while, I would just bring all my own equipment because there was nothing more frustrating than getting to an office and that day, they weren't prepared for
yeah.
me and my schedule and my equipment. So I just started bringing all my own stuff. Or like you said, I started investing in extra equipment and leaving it there. But I too, I got tired of that, and I got tired of the traveling, and the turnover that the other offices had was affecting me, and I'd have to retrain the assistant. And so now is credentialing typically, with insurances, is that like the biggest holdup and kind of the biggest headache with this whole process? Especially like my office has two PPOs in network, but you just mentioned that there's some offices out there that have, 10 or more. Does that make it increasingly more complicated and longer to get started?
Yes and no. Um, it really depends on the office's ability to line up uh, out of network days initially, and the specialist's flexibility to want to. The specialties that are more amenable to starting off like half days would be uh, ortho, pedo, perio, and surgical pros. Because surgical pros can come in just consult for one full arch case, and it's worth 3 treatment
Mhm.
days. The specialties that aren't so open to half days to get started are oral surgeons and endodontists. But endodontists, I I just want to kind of mention that it's the highest demanded specialty that we see across the country,
Mm,
and a lot of offices don't really realize how like luxurious it could be having your own endodontist. So you have to know, what specialty persona you're dealing with in regards to being able to feed them the right cases, bringing them in as often as you think would be optimal. Because what I mean by that is you may end up with like an endodontist that's like 10 miles away, which is super close, and they may be okay with like a half day. Um,
mhm,
but proximity plays a big role in them wanting to play half days, and also most endodontists prefer to go out of network, and we always suggest it because the practice can actually end up controlling the billing a bit more, where the restorative gets allotted towards the insurance's portion, and the endo procedure side, you could bill out a network and not be contracted or cuffed to any rate that the insurance gives you. And endodontists are only really able to do sort of number of procedures in a day,
mhm,
as opposed to oral surgeons. You can come with a staggered schedule. Perios can, produce a wide fluctuation of production dollars for a day. Endo is much more straightforward, and there's not that many of them around. Is the other challenge. Keep in
mhm.
mind.
Okay, and what about pedo? It seems like pedo, I would probably just like, I would take the day off and just have the pedodontist like take over that whole day, because it seems like that's more of like a typically a higher volume type of day where they need all my assistance to help them. Is that pretty consistent for what you're seeing? Is that pedodontists need a bit more of chair space and staffing?
So, depending on how big the office is, of course, right? But your
Mhm.
typical practice, like 5, 7, 8 ops, they would usually dedicate the day
Yeah.
just to specialty. Um, and you really can't bring in hygiene because they have to be under supervision of the GP while they're there, sort of thing.
Yep.
Most of the practice owners that we've seen, after like things get into the swing of things, they take that day off or just handle admin. They enjoy their lifestyle better that way too,
Hmm.
because the place, like, they have peace of mind that the practice is producing more than what they could produce that day, and their patients are getting treated by a board eligible, board certified specialist. And you know you could just take the day off or focus on admin stuff, things that you just really need to get to in order to enjoy your career as a dentist more. I think
That's
it's
such
really
a that's such a great point. That so not only am I keeping these patients in house, I'm not referring them out, which is huge. To keep your patients in house is huge. They don't want to go anywhere else. They want to stay in your office. Um, and when you refer them out, there's that loss of revenue. Sometimes you're referring, they don't go through with it because they just don't call the office and it just doesn't happen or it gets delayed. But also, like you're saying, I could take the day off or reduce my schedule and have the specialist come in, especially if I have a small office with only, let's say 3 or 4 chairs. Give them that day. I take the day off, do admin, and I'm still making revenue, and our patients are getting taken care of. So I think that's win-win.
totally, it's a win-win-win even for the patient, because
Hmm.
a lot of them, they don't feel that comfortable going to an unfamiliar setting to get specialty treatment done. There's a huge difference of the rate of conversion from patients that get referred out versus patients that get referred in. I'm sure a lot of GP practice owners or any practice owner that refers out cases out there is listening. Um, Not every patient that you refer out ends up coming back. I'm sure they realize that.
Yeah, with implants, we have our own CT scan, CBCT, and I found when I didn't have the CBCT and I was referring patients out to another office or to a CT scan center, a lot of times patients just wouldn't go through with it. And then 6 months would come around and say like, hey, did you get that CT scan? No, I never got around to it. But now that we have one in office, they're staying in the office and they're more willing to go through with it. And that goes for a lot of the specialties. Okay, I got to ask you about this. What is the 99-cent pregnancy test, and how were you involved with that?
I invented the dollar pregnancy test. I don't know if anybody's ever seen them in the checkout aisles of the 99-cent only stores or Dollar General, but my brother-in-law is OBGYN. Story goes, I was just walking through Rite Aid, the pharmacy with him one day, and I asked him like, how do you test women for pregnancy when they come in to the hospital? He's not private practice; he does hospital work, and he said, "Well, we use the strips that are inside the encasing. We don't actually buy, $25 EPT test." So I said, that's interesting. I went online, I found a factory in China that would sell me the strips, the HCG test strips in the form of these large planks. And so we imported them. I connected with an FDA approved factory in Mexico, Tijuana, across the border from California, that had the machinery to chop up the planks into strips. And then I packaged them up using a charity service through Goodwill that employed handicapped people. And lo and behold, like I developed the 99-cent pregnancy test. Eventually, due to competition just pouring in, uh, I ended up closing it down.
So, I mean, this is like a seamless transition going from, pregnancy tests to pairing dental offices with specialists. How did you get into becoming the co-founder of Paradental? What's your story there? How did this whole thing happen?
Well, I've always been in dentistry. I'm 40 years of age now, and when I was a senior in high school, I was 18 years of age, selling latex gloves door to door to dental offices. I had a pager back then, a beeper. Cell phones are too expensive in '98, and I ended up building a portfolio of dental practices that just started buying their disposables for me. And then later on, I connected with some of the other manufacturers that wanted to open me up as part of distributorship, and I thought that was an easy way to add revenue because I'm already selling them the disposables. And here I am operating a full-blown dental supply company called Darden Dental Supply back then. The recession hit us pretty hard, but we ended up exiting to Benco Dental, the distributor in the Northeast. And I worked for Benco for about 3 years. I got a taste of the corporate side of dentistry, as a territory rep. I opened up the Southern California territory for them, and we ended up doing fairly well. I was with them for 3 years, but when I was working for them, I got out of the office more. I was visiting accounts now. I'm a territory rep, and I noticed like all the challenges that these practice owners were going through, because this was like around '08, '09, where the recession really caused a major obstacle for practices to bring in patients and convert them for treatment. And at the same time, specialists graduating with all this debt, they can't really go and open up a private practice that easily. Even if they had a daddy's money coming in, it's not like they can attract a referral base off of that. It's not one of those situations where if you build it, it will come. So I said, well, what if I set up the first iteration of Paradental, which is it was called Synergy Specialists back then, where it was set up more as an agency, a very boutique agency, where it was myself and several staff members. We operated things on a spreadsheet and just kind of understood personalities to network. Now, ever since our CEO, my business partner, Dr. Alex Malayam, came on board, we've been transforming it more into a tech-based marketplace. We're launching a member portal app that is going to be the front-facing product that both the practice owner and the specialist can log in. Very similar to how Uber has an app for their drivers, or equivalent to our specialist, or Airbnb has an app for their hosts that want to rent out their homes. You'll have all the data points and everything at your fingertips to know what you need to know for itinerant specialty.
Awesome, man. That's a great story. So just wanted to clarify. So Paradental if let's say I'm hiring a periodontist through you, you're matching us up. I don't actually have to pay you. Your fee comes out of the periodontist's percentage. Is that right?
Correct.
So it's really risk free
It is.
for
Um,
us.
yeah. I mean, there's an investment of supplies.
Mm-hmm.
For perio, you have to probably invest, $500 to $700 worth, but that's worth probably multiple treatment days.
Mm-hmm.
And all of our services, as far as like training the office, teaching them how to do the billing, getting set up with the right match, getting the specialist to meet with you face to face, that's all included with the percentage that we get paid to the specialist. The only two outside services that we charge a la carte are, number one, credentialing, because we outsource it to a third party. That's a $200 setup fee plus $100 per application, and it's optional, of course. If the practice wanted to do it themselves, which we don't really recommend because it's a burden on the office manager, we'll forward you the specialist's credentialing packet in an organized email. We're all about saving time. And two is, if you want us to do the billing, just like any other biller out there, like a remote biller, we charge a small percentage of the collections that comes in. We do billing for restorative general dentistry as well too, not just specialty.
Okay. And as far as compensation for the specialist, is that something I negotiate with them? How does
Yes,
that work?
definitely. We'll attach a copy of their fee schedule to the meeting introduction, so you'll have some sort of context to discuss the percentages and the fees and all this stuff when you meet with them face to face. Ultimately, it's at your discretion with the specialist. They know coming in that for us being the matchmaker and setting everything up, that we're taking 5% from the specialist's portion.
Mm-hmm. Now, so could it be based off of collections, adjusted production, per diem? Is there just a lot of different ways you can go about setting up the compensation?
So collections doesn't really work out long term. I can tell you a little bit why later. The model works mainly on an adjusted production model.
Mm-hmm.
It's supposed to be intended for a true 50-50 split.
Yep.
The difference, there's many definitions that loosely float out there. Most of these deals are done on a spin on a handshake type of arrangement. They don't actually sit there and defining this stuff in a contract. The way we like to define adjusted production is, it's the combination of the in-network contracted rates plus the co-payments plus the out-of-network payments that were collected, uh, out-of-network and cash payments collected. So, and how that works is, you have the specialist's UCR fee schedule. That's their fees. They'll tell you if they'll give you a verbal if they're flexible to discount off those fees or not, right? That's part of the meeting framework agenda that you should go over when you meet with them, actually. And you have to collect that fee in advance of the treatment. And you can tell the patient that you're going to do a courtesy billing out of network for them. Depending on the insurance, the patient may end up getting the reimbursement check. It's important to let the patient know if that's the case or not, so they don't end up calling your practice wanting to collect the money that they're expecting from the insurance. So that's the combination of the fees that would add up to an adjusted production. And then if you're getting downgrades from insurances or charge-offs, you just take it off on the following treatment day payment. The biggest concern that most specialists have is that they can't track the collections numbers. They're just working as independent contractors. And a common argument I see once in a while from a practice owner as well, they have access to my books and records and they can go and check anytime they want. And the thing is, though, that as a specialist, you're making so much money and you're so focused on patient clinical care and like 24 settings, practice settings, that you just don't have the time to like put in to go and like check the records, this and that. So the adjusted production model lends a helping hand to creating a true 50-50 split. If the practice owner says, well, we want to make payments after we get money from the insurances, that's okay. We could write up the contract with the specialist's blessing, of course, where we do it on like a net 30, let's say. So that gives you enough time to collect from all the insurances and what have you. One thing is for sure, though, if you're going to start specialties such as like surgical oral surgery and implants and what have you, it's very important that you know going into it, you're gonna have to like lay out some cash flow, not expenses, but cash flow, because the amount that like an oral surgeon comes in and produces is great and all, but sometimes it's so much that you're going to have to wait for some of the insurances to pay you, which if you know that they're going to pay you and your billing was accurate, which is how it should be, then you should be fine in terms of profitability. Every specialty should be profitable.
Mhm.
Ortho is probably the most difficult to get profitable. um, it involves the practice buying the instruments and the equipment, and it's more per diem based
Mhm.
rather than percentage based from the deals that we set up. So you'd work out a deal with an orthodontist on, like, let's say a 15, 16, $1,700 per diem plus $100 to $200 bonus on each new case start, sort of arrangement. And with pair, it's the same setup. We take our fee from the orthodontist side,
Mhm.
just like we would on the surgical specialties.
What's the biggest money maker? Would you say, is it oral surgery or surgical prosto?
Surgical prosto, if the practice can line up ample full arch consults and implant
Mhm.
cases, it can definitely be more productive than all the other specialties. But the far most common specialty that is under the champion belt of productivity is oral surgery.
Mhm.
Insurances just pay a lot for third molar extractions for the most part, and fee for service offices that are capable of lining up 7 cases of just wisdom teeth and
Yeah.
IV sedation can easily produce $15,000 a day, and be done by like 12 noon, sort of thing.
Yeah. I went
Um,
to a local oral surgeon to watch him for like a morning. And I mean, he popped 4 wisdom teeth out in like 5 minutes. And I was like, I mean, I've never seen, I mean, it can be really productive, implants and third molars. Um, yeah, ortho, like you said, would worry me a bit because a lot of times these are, the long game. These cases can go for a year or a year and a half or 2 years. And that would just concern me that, what if it didn't work out and we're in the middle of a case, um, and the orthodontist, and us, part ways. And then, how does that work?
well, it's eventually going to happen because they're not
Mhm.
partners in the practice; they're just
True.
independent contractors. It's a
Yep.
very valid concern. I get this concern pretty often from any owner doctor. It's not the most common specialty that started with us. 80% of the practices that come to us, they're new at specialty in general. So they come in, they start with like OS, perio, or someone to do implants or endo, of course. But working through pair helps with having some predictability if the orthodontist is thinking about leaving. If we have a little bit of notice, we can go and talk to the other orthos that we have to come and take over the cases. The other scenario that I see fairly often is that the general dentist does the aligners again until the ortho comes in.
Hmm.
I think it's the conventional braces that becomes a challenge when you start those cases up, because the treatment planning is done more with autonomy through the orthodontist without any, third party aligner, CliniCheck type of involved. And if the treatment was not done to the liking, I'll say, of the next orthodontist coming um, in extreme situations, they have to deband the cases and redo them. It turns into a nightmare type of
Yeah.
situation. It's really important that you have an understanding, either over your initial conversation with the orthodontist or in writing, about what a termination period would look like. So ideally, you want to write up a contract with the ortho where they give you at least 90 days notice to disconnect. So upon termination, you would cease to send any more consults, and they would just continue to come in under the treatment days that they committed to, and the practice would start finding an orthodontist to replace them,
Hmm.
sort of thing.
Okay.
Although they're independent contractors, you have to, I would talk to your lawyer about how to structure that agreement. Or, if you do work through pair, we could always see about structuring those sort of agreements too, because we do have the longevity of the match, that best interest in mind, because unlike a dental recruiter, Eric, it's kind of like this, right? A dental recruiter comes in and charges like thousands of dollars up front,
Right.
and they'll just flip you a resume. It's very labor intensive to like start these conversations with clinicians to see if they're interested in a job. People don't really realize like the whole matchmaking element requires like hours and hours of conversation and texting and emailing and what's it all about sort of thing, right? um, we we save the practice owners a lot of time and the specialists a lot of time. That's probably the biggest pain point that we're able to initially help solve for practice owners that are interested in starting specialty.
Oh yeah, the time and the guidance that you're offering. Let's say I just opened my practice, so maybe I'm a year or two out, and I don't know how to do any of this. I don't, so you're there as a matchmaker, a guide, and almost like an intermediary. But like you said, you're not just finding them and then we never hear from you again. You're kind of in for it for the long haul as well. So I want to just end on IV sedation. Let's say I have maybe once a month, I want to start doing some sedation cases in my office. And I want to bring someone in that can sedate my patients. Can you explain that whole process? And is that also comes with a lot more risk to my office, correct?
It does. A lot of oral surgeons don't want to start doing IV at least for a few months until they feel comfortable with the staff and the facility and how the patients are getting screened out. Patient candidacy is crucial. We have a whole patient candidacy guide in our training manual. I'd be happy to share it with all your members if they want to email us. And basically that reviews what sort of patients to avoid referring in and what sort of patients that are ideal candidates. There's an ASA chart classifying body types, body weights, medical procedures that were done prior that would eliminate candidacy for patients and what have you. And the surgeons are also looking for practices that are organized and capable enough for lining up the right patients. They don't want to end up with an office that they start with and the office like just the manager or the owner dentist just like disregards the type of patient that's being lined up for IV sedation. Surgeons, I get calls from them all the time saying, "Oh, I got this practice. They drove me crazy. The second time I told them don't line up a patient with a pacemaker. Like, what are they thinking? I'm dealing with IV sedation. This is not a joke." They take it very seriously from an organizational perspective.
So that's an oral surgeon, but what about if I want a sedation specialist that comes in and can sedate the patient while I'm working on them?
Yeah. Um, they they are available by like state to state sort of arrangement. There's not that many of them around. I'm not even sure. So in some states, a sedation specialist that is allowed to perform sedation without any supervision allows for a CRNA in addition to a dental anesthesiologist. And I know in California that's allowed. In some other states, they allow CRNA as well too.
What's that?
But in some states, they allow a CRNA to come in and
is that a certified
registered nurse anesthetist?
Okay.
I believe that's the full abbreviation.
Gotcha.
But the anesthesiologist or the CRNA would want the same level of like organization and patient candidacy that the oral surgeon would want for any IV sedation.
Yeah, I mean, I think that would be such a nice thing to have because I have some patients that are they're too phobic and they just don't get work done because they're too phobic. So Darius, thank you so much. Again, Darius Somekhian is the co-founder of Pear Dental, and you can go to dealsfordentist.com and you can find their promo offer. they're offering to be a zero-cost matchmaker for getting paired up with a specialist. Darius, thanks so much for joining us.
Oh, this is my pleasure. Thank you so much, Eric.